So thank you everybody who is joining us today. It's such a pleasure to have you with us. I'm going to introduce myself quickly, and then I'm going to pass it on to our panel here. My name is Stacy Swiderski. I am the CEO and the founder of Family Source Consultants. We are a surrogacy and egg donation agency headquartered here in Chicago. And we facilitate approximately around 150 to 180 or so surrogacy journeys per year. We have been building families now for 14 years. So it's as a previous intended parent myself, it's quite an honor to be able to assist these intended parents who are building their families. So I'm going to pass it on to the panel here, and I know we have about an hour or so. So I'm going to pass it on. I'm going to start with Perla, who is our vice president, executive vice president here at Family Source. And then Perla, we'll go from you to Shantae to Dr. Levy.
Stacy. Hi, my name is Perla Peketowski. I'm the executive vice president for Family Source Consultants. Like Stacy said, I have been helping create families for 11 years now, and I have had the pleasure of working with this beautiful panel for many years. And I'm just so humbled to have the opportunity to get to share in our expertise and talk about the process with all of you.
Thank you. And then Shantae.
Hi, my name is Shantae, the director of the third-party program here at New England Fertility Institute. I've been here with Dr. Levy for about 19 years. I am an experienced egg donor myself. I run the donor program here and we have about maybe anywhere from 100, maybe 80 to about 100 egg donors, but we also work with Stacy, who has an egg donor program herself, and with Perla. And we also work with, my apologies, I just got stuck. But yes, we work very closely with Perla and Stacy, and thank you for joining this webinar.
And so 19 years, you typically have grown up there at New England.
I would say so, yes.
Yeah, wow. You really look 19. Oh, Dr. Levy.
My name is Dr. Levy. Our clinic is in Connecticut, in Stamford. I've owned this clinic for, I would say, almost 30 years. I stopped counting after 20. And we basically are a fertility clinic, but essentially specialize or focus primarily on third-party reproduction, egg donation, and surrogacy. So thank you all for being here. And I'm very happy, very honored to share this webinar with Stacy and her agency and Perla. So we've been friends for a long time, and we're very happy to talk to you tonight.
So thank you. We are really looking forward to just sharing the ups and downs and the beginning and the endings to building your family through surrogacy and egg donation. I think it's best we already have questions lined up. So I think we're going to save those towards the end and start with Dr. Levy. I know you have a PowerPoint, and many of our questions that we already have are medical related. So I think this is going to be super helpful to get this started and have you go through step by step. And we may have some questions myself or Perla or even Shantae during your PowerPoint. But yeah, let's start there. I think that'd be great.
Excellent. Thank you, Stacy. So first, I just like to point out that, I like to actually show the process and the different parts of this process, sort of the big picture, and always at the risk of this being a little bit intimidating, a little overwhelming, because as you'll see, there are many moving parts in this process. And of course, for it to work, everything has to be just right. And our job as a team, and this is really a team effort, and the team includes all of us. Our job as a team is basically to handle the technical parts of the process and allow you to essentially focus on the important stuff. If you need an egg donor, how you find your egg donor, how to find your surrogate, how to be comfortable with this whole process. So I already mentioned we've been in the practice for almost 30 years, and we're focusing on egg donation and surrogacy. We're not a large clinic. We're not a small clinic, but basically the idea, my idea all along, was that we should be able to provide personalized care. And because this is a very highly emotional area and a very highly emotional process. And for that reason, I think we found sort of a meeting of the minds with Stacy and her agency, because I know that they have the same views and the same approach. So we're on the East Coast, we're in Connecticut. We're about maybe an hour north of New York City. And nowadays it's maybe not so important where we are, but essentially we're very convenient to the airports in New York from nationally and internationally. I'm very proud to say that we actually are practicing, I would say, the cutting edge, the state-of-the-art technology, and basically translates into a very high success. So I can say that we have approximately 80% success with a single embryo transfer.
Dr. Lee, if I'm just going to butt in really quick there, if you don't mind. When you say 80% now, is that, can you specify, is that with genetically tested embryos?
Right. So Stephen, if you can just back up the slide for a second. So how do we get this high success? Basically, the idea is that our goal is to transfer a single embryo and to be able to identify, to pick the most viable, the strongest embryo that will give us the highest success. So the way we do that, and I'll show you when I show you the process, we grow the embryos for 5 or 6 days in the laboratory. That allows you immediately to identify the more viable embryos. And in addition to that, we also do genetic testing for those embryos that further identifies those embryos that have a better chance. So that allows us to increase the chances of success, reduce the risk of miscarriage, and of course, lower the chance that the process is not successful. So yeah, please move on to the next slide. And the next slide after that. So this is maybe in a nutshell, basically the whole thing. So this is really all you need to know about the medical part of the process. And as you can see here, we do the medical part in 2 very distinct parts. The first part is where we create the embryos, embryo creation. In this case, we show an egg donor, but this could be actually the female partner as well. And they will go on medication for about 2 weeks to basically boost up their egg production. So instead of the 1 egg that a woman produces in a natural cycle, with an egg donor, we can easily get 15 or 20 eggs. After about 2 weeks of treatment, there's a very simple office procedure. We call it the egg retrieval, where we harvest the egg. It's done in the office with a vaginal ultrasound, and basically the woman can leave within a half hour to 45 minutes after the procedure. And then we have the eggs, and then we add the sperm, we make the embryos, we grow them in the laboratory for 5 or 6 days, and wait for them to become what's called the blastocyst. That's the final stage in the development of the embryo before they need to attach themselves to the uterus to keep growing. And then out of those blastocysts, yes. Out of those blastocysts, we know that even though they may look beautiful under the microscope, some of them are not truly viable because they're not genetically normal. So we will do it's called PGS, pre-implantation genetic screening, which allows us then to determine that the embryos have the right number of chromosomes, the 46 chromosomes.
Can you explain the difference? And I actually just had this question the other day, and I'm aware what it is, but just for you to share with the audience, what is the difference between PGS and then PGTA? Because
so actually this is just the name. It's the same process. So basically just recently the nomenclature, the name has been changed from PGS, pre-implantation genetic screening, to PGTA, which is basically checking for aneuploidy. There's 2 types of genetic testing that we do on the embryos. One is to basically count the chromosomes, and the other, which we don't do very often, is to actually check for specific gene defects like cystic fibrosis and thalassemia and muscular dystrophy. This is for people who actually carry those genes, and we want to identify the healthy embryos. So the typical procedure that we do is PGS or PGTA, which essentially checks for what's called aneuploidy, which is an unbalanced number of chromosomes. So these chromosomes, like if the embryo has 45 or 47 chromosomes, those embryos are not viable and would unlikely implant, or if they do, they will end up in a miscarriage.
Harvey, I have a question too about PGS. What is the
Yes.
accuracy rate? In other words, how often do you get a false positive or a false negative?
So this is, the PGS, this is what we call version 2.0. So this is the second generation of PGS, or actually probably the third generation now, which has a very, very high accuracy. So it's over 99% accurate. And what it is essentially you grow the embryo all the way to the blastocyst stage, where the blastocyst has about 200 cells. So it goes from 1 cell on the first day to 200 cells within 5 or 6 days. The other thing that is true about the blastocyst, that it's actually, you can very easily identify the part of that blastocyst that will become the baby and the part that will become the placenta. And that allows you then to take a few cells from the placental part of the blastocyst of the embryo and then do the genetic analysis. So the thing is if you take more than 1 cell, the more cells you take, the higher the accuracy of the test. So normally we take 4 or 5 cells, and that clearly is very safe to the embryo, but gives you a very high accuracy rates.
How often do you see an embryo that does not survive the thaw?
So essentially, as far as the IVF process in general, we've seen tremendous advancements in the last few years. So one of them is the fact that we can grow them in the laboratory for 5 or 6 days. In other words, provide them with the proper conditions, temperature, humidity, nutrition, to grow for that long. The other thing that we can do the genetic testing, again, without harming the embryo. And finally, the fact that we actually have a freezing technology now that essentially does not affect the viability whatsoever. So I would say that of course it happens. It's very, very rare that an embryo does not survive the thaw. And what I can tell you that almost all of those embryos that don't survive the thaw are not good embryos. So in a way, it's sort of a way to weed out.
Kind of a blessing in disguise.
Yes, exactly. So it's very unusual.
Right.
So at the end of the first part, the embryos are frozen, all of them. And then we basically wait for the second part, which is, we call it the frozen embryo transfer. In this case, it will be a surrogate, as you can see, but again, it could be the female partner using an egg donor or using her eggs. The process is exactly the same. And then in this case, the surrogate will prepare for about 3 weeks, usually using some hormones. I generally prefer actually to use her own natural cycle if she has a normal cycle. And then just at the right time of the cycle, we usually take 1 embryo out of the freezer and put her in her uterus. What you see here, it says 75%. It's sort of 75, 80% success with 1 embryo.
Can you share the difference? Go ahead.
You go ahead.
I was just going to ask you, can you share the difference between the natural cycle and then or medicated cycle?
Yes. So I think sort of the tradition in IVF was to basically, when you do a frozen embryo transfer, is to use what we call a medicated cycle. It's an artificial cycle that you create. You use basically the same hormones that the body makes, the estrogen and progesterone, but you basically create an artificial cycle. And that allows you, based on the number of days of these hormones, to determine when is the right time to do the transfer. So there's certain advantages to doing it this way because it's very predictable, allows you to plan. But what I found over the years that, especially with surrogates, because we basically have young, healthy women that have conceived naturally, that the less you interfere with their own cycle, the better. So if you can take basically the surrogate in her own natural cycle and just find out exactly when is the right day to have that embryo put in her uterus, you get better results. And also it's easier. It's easier for her because there's less medication. Actually, there's only one injection, whereas the other protocol has multiple injections for a good few weeks. So, we get good results. The surrogates like it because it's easier. So, the only downside of doing it is that, every woman may have every once in a while, even if she has normal cycles, every once in a while a cycle that's not good. And those cycles basically we will cancel before the embryo transfer. So there's really no risk except the fact that it may delay the process if the cycle is not good.
Right.
Just 2 words about the table there on the bottom where it says success. We do occasionally do 2 embryos. Of course, if you transfer 2 embryos that are good quality, genetically tested, you expect a high success. And indeed, we get over 90% success. But also we get a high incidence of twins. So 60, 70% of those pregnancies are twins, which is fine.
And what?
Yes.
Right. I was going to ask, so in what situation would you allow or even recommend transferring 2 embryos?
So I highly recommend against doing 2 embryos if the couple comes to me and says, we really don't want to have twins, but we want to increase our chances of pregnancy. Because then you end up with twins and you sort of wonder how that happened. But for people who come and say, we really want to have twins, and they understand that, there is a higher risk for a twin pregnancy, then I think it's okay. And if they do want to have twins, so we will work with Stacy, with the agency, and we will find the right surrogate. So my opinion on twins is very different in a surrogate than it is in someone who's never been pregnant. If you take a woman who's never been pregnant, I don't think it's a good idea because she doesn't really have much of a track record. But if you look at surrogates who basically are only chosen if they have children, if they have previous pregnancies, then you can basically determine if a certain person is a good candidate for twins. She had twins before, she had basically good sized babies full term. These women are, in my opinion, good candidates. And even though their risk is a little bit higher than carrying singleton, it's much less than someone who's never been pregnant.
How often would an embryo split into 2?
So when you do 2 embryos, like I said, 60 to 70%, the chance of any one embryo splitting is way less than 1%. So, of course, it's when it happens to you, it's 100%, but it almost never happens is the bottom line. It's not something that you should worry about or think about when you do the transfer.
Thank you.
Perfect. All right.
So, and just to quickly review this, because, as I said, our field has basically undergone tremendous improvements over the years. And so you can basically, if you have a couple who wants to have a baby and is willing to take advantage in what we have to offer, they're pretty much guaranteed to have a baby. So that sometimes means that they have to use an egg donor if the woman's eggs are not good. Sometimes have to use a sperm donor, and of course, sometimes have to use a surrogate. The exception, of course, is gay men, gay couples that essentially have to use an egg donor and have to use a surrogate. But the idea is that you can sort of, in that previous chart that I showed you, you can substitute the donor and the surrogate with, the female partner. And you can substitute the sperm with a sperm donor or with a partner sperm. So any one of those permutations is possible. And again, depending on the situation, depending on your issues, there is sort of a combination that is pretty much guaranteed to work for you. Next slide.
Yeah, we used to see quite a few, many of our intended parents are same-sex couples, and we used to see many double embryo transfers up until probably the last few years or so. And now we're seeing even many of those intended fathers who they do, they have created embryos with both of their genetics, and they are still sticking to a single embryo transfer with the hopes of, a sibling down the road once their baby's born. We've even had intended fathers who are working with two surrogates at the same time, or maybe staggered a little bit. So yeah, so many options for sure.
Exactly. And this is a discussion I have often with the parents. And you're right, especially with same-sex male couples, because they basically, many of them come into this process wanting to do two embryos, to make embryos for both and transfer two embryos. And once they learn that it may be a little bit more difficult, actually there's some insurance issues, especially for couples that are not US citizens.
Especially international, right.
So they say, well, okay, maybe we won't do that. Maybe we do a single embryo transfer. And I've had recently a few that actually decided to do two surrogates at the same time, which is, a little bit, a little bit of a challenge, but works.
Yeah, as long as it's transparent to the surrogates and they're comfortable with it as well. We definitely, if they want to have two children and have them close in age, it's next best thing to twins, right?
Exactly. So I just wanted, because we don't really have a lot of time, I just wanted to basically quickly explain how the donors are chosen and how they're screened. Basically, the bottom line, we are looking for women who are healthy and have good eggs. So we go by their medical history. We only pick young women, non-smokers, and then we put them through a very extensive screening. I'll show you in a second. And then they go through the process. Typically, we get 15 to 20 eggs. Typically, we end up with 5 or 6 genetically normal embryos. So that's another thing that you need to realize, that people often are disappointed. We start with 20 eggs, we only have 5 good embryos, but that's normal. And if you consider the fact that these 5 embryos each have about a 80% chance, that's sort of a good number, because it's definitely more than enough to have 1 or even 2 children. One thing that maybe I'll touch on briefly is, fresh versus frozen eggs. And again, we can talk about this for a good hour.
Yeah, we actually have a question for that. So yeah, a fresh versus frozen eggs and embryos, the difference in success.
So as far as embryos, I mentioned already that the technology today is such that there really is no difference between fresh or frozen embryos. So we don't lose any viability or embryos in the process of freezing and thawing. And that's been true for actually quite a few years now. Eggs are a little bit different. Eggs actually it's always been a challenge to freeze eggs successfully. And the new technology that's been around now for about 5 years, plus minus, then allows us to get the same success with frozen eggs as we do with fresh eggs. Which means that if you have a donor that's already been through the process and her eggs have been harvested and frozen, you have the option of using her eggs. So that gives you more to choose from, allows you actually to determine or decide how many eggs you'd like to get. And many people do that because if you only need a few eggs, then it's less expensive than doing a full cycle with the donor.
And some intended parents may not be super comfortable having an excess number of embryos either, left over. So
that's a discussion we always have at the beginning, because it really depends on the couple, the parents, the individuals, and first of all, what are their plans for family? How many children they want to have, and how they feel about having leftover embryos. Exactly.
Yeah.
So so you have to find a solution, and there is a solution for each individual, each couple that comes into this process.
Do you feel that a frozen embryo transfer has higher success than a fresh? Back in the day, it used to, right? It was kind of flip-flopped, and now it seems that frozen is definitely more desired, especially with surrogacy. It's easier to plan as well.
Well, I'll tell you, I mean, first of all, people come with the sort of misconception, forgive the pun, of basically the fresh is always better than frozen, right? It's like you put the chicken in the freezer, it's not as good as it is when it was fresh, but it's a whole different thing. When we freeze cells, we freeze them in a completely different way. We freeze them in a liquid nitrogen, which basically allows them to stay frozen indefinitely. And in those cases, actually, they're truly frozen in time. So, you freeze them today, and whether you use them in a month or a year or 10 years, there's absolutely no difference. So, so people do have that, and I think that sort of circulates around the internet probably still.
Yeah, for sure. Do you feel that the length of time that embryos are frozen will make a difference in the success rate, say versus 3 years frozen versus maybe 10 years?
Not at all, not at all. And again, that's a little strange. It's a little hard to grasp.
Yeah.
But when you freeze like something in your freezer at home, what it does essentially, it slows down the deterioration. It slows down the spoilage. In liquid nitrogen, the temperature is low enough that all the activity stops completely. So in other words, it doesn't really matter how long they're frozen. And we have patients, actually, we just recently had someone who had embryos frozen for, I think, 15 years. And they came back and had twins, actually, from the double embryo transfer. So yes, the answer is definitely not.
After 15 years?
Well, it's an interesting story. I mean, somebody gave them those embryos as a donation.
Okay. Oh,
And
nice.
that family had kids and kept those embryos frozen for 15 years and then gave it to them. So that was sort of a really nice story.
It's my husband and I, we have 10 that are frozen, and it's been about almost 16 years. So we're in that situation where we're not having any more children, and I don't want to dispose of them, and he doesn't want to donate them. So
I know. Well, I mean, exactly. And this is something that people need to consider, because if you have extra embryos, leftover embryos, and you've completed your family, you need to be prepared to make a decision.
Right. Yeah, for sure. While we're on this topic, I'm going to, I have a few questions, and I just want to try to get everybody's questions in before we wrap up the webinar. And it fits right into this topic. But one of the questions we had emailed to us actually was, we have an intended father. He has 7 embryos that are female and 3 that are male. And he was curious which is best. Now, I know that's kind of a pretty variety of a question there, but if he wants to synchronize these for future transfers or maybe siblings, obviously I know there's male, female, he knows what the genders are, but I think that's kind of a open-ended question in terms of what's the best quality. I guess it would just depend on what the best quality is. You would want to start out transferring the best quality.
Yes. So
unless it's gender specific, of course.
Well, so in addition to the genetic testing, we also look at basically what's called the morphology, what the embryo looks like, and we give it a score or a grade. And that grade does correlate to some extent with the outcome. So from all the genetically normal embryos, you can say, okay, I'd like to transfer the one that is the strongest, that looks the best, looks the healthiest. So we can do that. So some people actually tell us, we don't really care about the gender, just pick the best embryos. Some people, I mean, if you have embryos from both genders and you have a preference, of course you can do that, and we will pick the best embryo from the gender that you prefer.
Okay, great. Sorry to interrupt, but I wanted to get that question in there that he had emailed.
Great, no, that's great. And again, quickly, just to show you what we do to screen the donors. And essentially, just that that the screening is very extensive, exhaustive, and we I would say, lose most of the applicants. I'd say maybe 90% of the applicants just in the screening process. Because that's, for us, it's a big responsibility. And, you know, Stacy has her donor agency, we have our donors. And, you know, we want to be able to sort of stand behind and tell you, you know, these donors are good. They have good eggs and they're healthy. And then you decide, you know, based on whatever criteria you have, which is the right donor for you. But we want to make sure that the donors are medically healthy, they have no psychological issue, there's no mental illness, that they fully understand what they're doing, and making sure that they're not going to basically wake up 5 years from now and say, oh my God, what did I do? So we do that. We do a lot of genetic screening, and we make sure that, you know, the donor basically is a good genetic match. The egg with the sperm are a good genetic match. And of course, we do very extensive infectious disease testing. We call it FDA testing because it's that part of the screening is mandated by the FDA. So the bottom line, I mean, we will make sure that the donors are good.
Dr. Levy, there's a question. How many times do we allow our egg donor to cycle?
Yeah, that's a good question. And actually, in the US, that is not, there's no law that governs how many times the donors can donate. And there's also no registry, like a central registry that takes basically that keeps track of how many times they donate. What we go by is the guidelines that are actually put out by the American Society of Reproductive Medicine. And that is that the donor should only donate 6 times. Why 6? I still don't know. I mean, that's sort of a very arbitrary number.
You feel that it may be something, I always figured it was geared towards maybe the donor's future fertility.
You know, there's really no scientific basis to that. I mean, I think there's 2 reasons. You know, again, I mean, and why 6, I'm not sure, but one reason is because you don't want to have too many of this person's eggs in the world, out in the world. This is more of an issue in other countries, smaller countries, where the population is small, and basically you can have, you know, siblings or half siblings that don't know about each other. In the US, it's much less of an issue. And if you pay attention and you don't let the donors donate in the same geographic location, I think that issue is much less of a problem. And then the other is the health of the donor. And, you know, even though the procedures are very simple and very minimally invasive, there is a small risk every time you do it. So if you do it over and over again, you increase that risk. As far as, you know, harming the donor's fertility, there is no basis to that. So, you know, taking the donor's eggs with an egg retrieval doesn't actually deplete her egg reserve. So in other, these women, even if they donate 10 times, they're not going to go into menopause any earlier than anybody else.
Born with many eggs.
Well, it's those eggs actually. So let's say a donor produces 20 eggs in a cycle. Those eggs actually would have been destined to be lost even if she wasn't donating. Even if she was actually on her own natural cycle, those 20 eggs would still start to develop, but only one of them will ovulate. So what we do with these drugs, we basically allow those 20 to basically fully mature. So we're not really damaging or harming their future fertility.
Okay, perfect. There is a general question that did pop up. So this could be related to the retrieval process, or even the preparing for the actual IVF in terms of the uterine lining. Right. But it's a general question, and it states, what does it mean that the cycle is not good? So I know that could be a variety of reasons, right? But let's say we're starting off with a qualified donor, or even, you know, the intended mother is utilizing her own eggs, and whether she's carrying herself or a surrogate's carrying. What would you feel that would make a cycle not to be good?
Well, I mean, that's a really good question. And I think it's not a simple answer. I think it's really it's all about the expectation. So basically, before we start, we do a very extensive hormone evaluation. And based on that, we can pretty much predict how that person will perform, right? Meaning how many eggs they can produce. So for example, with a donor, we basically, highly selected group that we know will make basically 15 to 20 eggs. So if you start the medication and after a few days you realize she's only making 5 eggs or 7 eggs, then that's not a good result, right? So in those cases, usually we will talk to the parents and often we just stop the cycle and say, well, we regroup and see if maybe we change the medication or we change the donor. However, if you're a 42-year-old woman that's coming to do IVF, then the expectation is different. And if you can have 5 or 6 eggs, that's great. So that woman, if we only had 1 or 2, then we say, okay, well, let's reevaluate and see if it's worth continuing. So at the beginning of the cycle, we basically assess the person who is going through the treatment and have certain expectation and then see how that measures to what they're actually doing.
They actually just, go ahead.
No, I was going to ask, what about for the surrogate? What is the bad cycle for the surrogate with both a natural cycle and a medicated cycle?
Right, that's kind of piggybacking onto that question, yeah. So meaning in terms of for a surrogate for the cycle not to be good. Thank you, Perla.
Right, so for the donor, it's about the eggs. For the surrogate, it's about the uterus. And in a way, the uterus is a little bit, it's sort of pretty easy to tell because we have certain expectation of how the uterus or the uterine lining, the inner lining of the uterus develops in order to be prepared for pregnancy. So while she's going through the process, whether it's a medication or natural cycle, we check her a few times before she has the embryo transfer and determine if it looks good, if it looks the way it should for that point in the cycle. And if it doesn't look good, we cancel the cycle before the embryos are thawed and before the embryo transfer. So yeah, so of course there are some natural cycles that are not good, that the cycle just doesn't progress the way it normally does and we just cancel it. And there's some medicated cycles where you give the surrogate hormones and the uterus doesn't respond at all.
Right, we've seen situations as well where, if a cycle is canceled, it's unfortunate because it's, now you have to wait again for the following month or 2, but it does not mean that it's not they have to switch surrogates. You can, manipulate a cycle or a completely different protocol and attempt again the next month or 2.
Absolutely. So, and again, that's something that's very important to understand that, first of all, that we don't waste the embryos. If the cycle doesn't look good, we stop. And then we look back and see exactly what happened and why. And 9 out of 10, we can actually bring the surrogate back with a modified regimen and then have a good result. So you sort of learn from what happened and then you do it differently.
Perfect. And another question we have here that just popped up is, do you have an age cutoff for a woman to carry an embryo created with donor eggs with her husband's sperm? So if she's in her late 40s, do you have an age cutoff for that with using?
Well, so you know what they say is what is old, right? What is an old person? It's someone who's 10 years older than you.
Always.
So basically, as I age, I basically see things differently. And I know there are some clinics and some agencies that have a very strict cutoff for age. I don't. I sort of like to maybe look at the individual and talk to them about the process. But for a woman to carry, strangely, right? I mean, she may be way past her menopause and have no eggs left and no ovarian function and no periods. But you can very easily, with some hormones, actually wake up her uterus and get it to be receptive. So it doesn't happen often. I would say most of the recipients of egg donors are in their 40s. But I've worked with women who are 50, 55. I've even had a 60-year-old. Again, it's a very unusual, I just want to stress that, but it has to be the right person. They have to be healthy,
Right.
and they have to have good support and all these things. But from a medical perspective, there's no real reason to limit the age of the recipient.
Perfect. Yeah, and I know recently there have been grandmothers who have delivered their grandchildren, for their
Yes.
daughters or their sons. So yeah, definitely, as long as the embryo quality is good and you have a healthy, uterus, then.
So of course, with the older mother, with the older recipient, you have to make sure that they go through a medical evaluation. We usually require that they do see a cardiologist, have a stress test, because after all, pregnancy puts a huge stress on your system. But nowadays, people take care of themselves and they work out, and 50, 55 is what used to be 40. So,
We like to say that, right?
I like to say that, yeah.
Me too. And for example, for our surrogates, our cutoff is 43. For our agency is 43. 21 to 43 is our age group.
And I think again, especially if you're picking a surrogate, of course you want to make sure that you've done everything that you can. And even though I have to say that we've had parents that came back with a surrogate and to have a second or third child, and by now the surrogate was 45 or 46. Even we had a 48-year-old surrogate, and she delivered actually 3 children for that couple, and she did great. She got pregnant, she had the baby. So I think you really, really have to look at the individual.
Yeah, there's always exceptions for sibling journeys and looking at the big health picture for sure. Another question did pop up. This is more related to the basically it's emotionally how to adjust for no genetic connection with the baby. I wish we had a mental health specialist on here, but just for our history, what we've seen through the agency and knowing so many people who have children through egg donation, they have mentioned they have never felt a disconnect. If anything, they say that they wouldn't trade their children for the world, for their own genetically related children. So, but again, this is and as a donor myself, on the other side of that, I have met my donor, the children that I was an egg donor for, and personally speaking, I didn't feel maternal bond to those children like I do with my own children. Mm-hmm. So it's a quite interesting topic for sure, and I'm sure it's everybody may be a little bit different, but does anybody have any feedback on that and information that they've received or shared?
Well, what I can say is that we're always aware that it's a huge step to take, right, to give up your genetics and to use an egg donor. So we don't underestimate that the magnitude of that step. And I know for a fact that pretty much everyone who ends up using an egg donor has that concern, has that feeling, maybe I'm not going to feel the same about the baby. So I think everyone has that concern. And I can tell you in the 20-some years in practice, I've never seen a single person who came back afterwards and said that, we made a mistake.
They have regrets, right?
I don't feel connected to the baby. I've never seen it happen, ever, not once.
Same here.
Yeah, but
it's kind of, go ahead.
What you mentioned, just because I'm actually in touch with a couple that I donated for, and you're absolutely right. You don't have that same bond. I see them and every so often, and it's not the same feeling as if I don't look at them as they are my children. Like I have my own children.
Right.
You're absolutely right.
Yeah, for sure.
And again, just to keep in mind that when we screen our donors, that's one of the things that we, of course, you have to feel the way Shantae just mentioned and Stacy just said. You have to feel that way in order to be a donor. If you can't get past that, then you should not be a donor.
Right. they're not fit for egg donation then at that point, for sure.
Exactly.
And on the flip side of that too, many intended parents will have a concern that they feel that their surrogate may have a connection to the child once the baby's born. And obviously there is no genetic connection whatsoever at all. And the same goes for that. We have never seen a surrogate, or I have never seen a surrogate who felt a maternal bond at all to that child. As a matter of fact, it's quite the opposite. They go into the process knowing that the child or the children are not genetically theirs. And they're so excited and proud to be doing what they're doing, and to see their intended parents meet their child or their children. So I think, definitely we see that on the other end, like I said, where the intended parents feel the surrogate might have that connection, and they don't.
Right. Well, I think exactly. I think often actually the parents worry that the surrogate will decide to keep the baby. And that's so far from the truth. In fact, the surrogates worry more about the parents not showing up to pick up the baby.
Right. Or being in the delivery room, or being at the hospital. Right. Yeah, but it's definitely a moment that the surrogates are looking for, to see that those parents for the first time with their baby. It's pretty awesome.
And and it's not obvious, but of course that's part of the screening. That's how you pick them. So if you have someone we expect to have trouble separating, we don't take her. They're not
absolutely.
Good surrogates.
Yeah, the surrogates they complete
the
psychological screening.
It doesn't happen by chance. I mean, there is a process, and this process, and what Stacy's agency does. I mean, they make basically sure and double sure that they've picked the right person, and they also, most of the applicants are turned away because for one reason or another. Right.
We probably accept maybe about 15% of the surrogates who actually apply. So for a variety of reasons. For sure. To touch base a little bit, Shante, this is probably a better question for you or Dr. Levy, whoever wants to pick it up. But in terms of what the requirement that you expect at New England Fertility for a surrogate, the basic criteria that you're looking at.
So I would say that, number 1, 2, and 3 is, of course, the fact that they have to have children, right? That's a given, because otherwise you can't be a surrogate.
Oh, look, we rolled right into that, and I didn't even know that was the next slide. There we go. Good job, Stephen.
So they have to have children. That's important for different reasons. From the medical side is the fact that allows us to review her pregnancies, her deliveries, her compliance, who her doctor was, which hospital she delivered. So we know a lot about her history, which is a very good predictor of how she'll perform with her next pregnancy. So that's number 1. So we check to see if she had any complications, diabetes, hypertension, early delivery, how she delivered, whether a C-section, was there any complications? And I just like to point out that for the parents, of course, coming into this with no experience really, there's certain things that may, make you think maybe she's not a good surrogate, like she's had a C-section, right? But the truth is that many times, I mean, the C-section was uncomplicated. The risk of having any problems with the future pregnancies is minimal. But what if she's had 2 C-sections? And what if she's had 5 kids? So all of these things, we sort of take into account. And I think for me, probably a big part of the approval of the surrogate is to get her own OBGYN involved. Because I always feel that as much as I can learn about her from her records, they know her. They basically took care of her, they delivered her. So their approval, their blessing is very, very important. And I will not go forward with a surrogate that does not have the approval of her OBGYN.
Right, and that's definitely an important aspect of our intake process when we are screening surrogates. Yeah, we require that OBGYN, that approval. And of course, we retain all of her previous pregnancy and delivery records. They're reviewed within our agency before we even start to begin the matching process, reviewed by, we have a licensed midwife on staff. Obviously, we know that does not take place of what you do, but we want to make sure we clean it up as much as possible before we do send that over to the fertility center. But yeah, definitely, as you had mentioned, the OB clearance it's so important to have that current clearance.
And you know, as with other things, I don't like to have like rules sort of set in stone, because I like to look at the individual person. So the surrogate, you know, she's had 5 pregnancies, 5 normal deliveries. I don't see any reason that she can't be a surrogate again. And, you know,
How do you feel about BMI?
So BMI is another thing that, you know, of course we prefer that they have a normal BMI, right? They have normal weight. But the truth is that, you know, we have actually, as it turns out, I mean, this is sort of the epidemic around the country, that people come in with a higher than normal BMI, but had a perfect history, perfect pregnancies, no complications. Again, those women will do really, really well. Unfortunately, some of the women that have high BMI have complicated pregnancies, diabetes, hypertension, and of course, that's not a good thing.
What would you consider too high? Or high, what would you consider? I know it's hard because everybody's built different, and like you said, healthy pregnancies. Like, what would your cutoff be in terms if you're just looking at your criteria? Ours is 33.
Yeah, I agree with that. I think 32, 33 for me is fine. Again, as long as everything else is all right.
Right. Okay.
Yep. And then age, again, we talked about that. I mean, most surrogates are somewhere between 30 and 40, but I don't think that matters. You know, we have younger and older that are just fine.
When we have a surrogate who is not local to your fertility center, I know pre-COVID, the surrogate would have traveled for the initial medical screening. Are you back to that where the surrogate has to travel for the initial medical screening, or are you still allowing it to be completed near her?
Yeah, this is yes. I'll go back to that in a minute. Stephen, just back up one. So one thing about COVID is, you know, it gave us, and I think it's going to be many years before we sort of really understand the impact that it had on our society and our way we think and the way we live. But we definitely have learned through COVID that there's more than one way to do things. So, you know, we skipped that sperm slide before, but, you know, one thing that we are doing now with COVID regularly is people, you know, we have couples that come from Europe and, you know, from other parts of the country that prefer not to travel. So we basically arrange for them to freeze the sperm locally, no matter where they are, and ship it to us so they don't have to come. And that actually makes it easier, and especially Europeans, because it's really, really difficult to travel now from Europe. In the US, not so much. So you can go back to that surrogate slide. So what you see there at the bottom is basically what we call the clinic screening of the surrogate. So once the records are reviewed and we find that the records are okay, we generally like to meet the surrogate in person in the office. I just think that it's a good thing because for myself, I feel like I become responsible for her. I become her doctor. So I just want to make sure that we have a connection. She understands what she's doing. We go over we do the medical testing, we do the psych assessment. And basically we explain the process to her, how the cycle is going to go, what medication she's going to take, and so forth. And, you know, strangely with COVID and all of that, we still are able in most cases to do that. We have surrogates that come from all over. We had someone from Wisconsin today. We had somebody from Texas the other day. But we have our COVID protocols in place that allows us, you know, I feel, to operate, you know, during COVID in a safe way. So the surrogates travel, we test them before they leave, we make sure that they're okay when they come in. But again, I mean, if somebody really, really doesn't want to, we manage and we work around it. So it's not an absolute, but I highly recommend that they do.
How do you feel about the for the COVID for the in terms of, I guess, creating a healthier for the travel process? Again, we've seen some intended parents who are just so nervous to have their surrogate travel. Is that something that you'd be open to doing? And this is actually, I had a consultation the other day, and the intended parent, that was part of her criteria in terms of a surrogate being local or not, and just really afraid of, they want a child so bad, but they're afraid of still the COVID. They're really, really afraid of it. So limiting the surrogate for that travel. So is that something that you definitely insist on, or would you be flexible with that?
No, I think at the end, it's really more about, the parents and how they feel and what they want.
Mm-hmm.
So, I mean, I can try to explain to them that we've had a lot of experience over the last year, and knock on wood, thank God we never had an issue. Surrogates traveling for the screening, traveling for the transfer, flying. Actually, again, flying, I think is very safe. It's safer than going to a restaurant.
I agree.
But
or
again,
Home
you
Depot.
have to be, exactly.
It's just packed every time in Home Depot or Target.
But again, they have to be comfortable, and some parents are not comfortable, and they rather find a surrogate who's local and within driving distance, and that's fine.
How do you feel about the vaccination?
Go ahead. Yeah, so what I'm showing here, actually, this slide is before the vaccine, right? So, and we were actually working, essentially doing all the procedures starting in May, after we were closed for a couple months. And the reason I felt comfortable is, I list here this slide, is, for example, it's strangely, but we find that it's very unusual to find the virus in the sperm or in the egg. Because for whatever reason, there are no receptors for the virus, it doesn't go there. Another thing that we found is that it's very unusual that the virus crosses to the placenta, crosses to the baby if a pregnant woman becomes infected. And then finally, because again, the way we pick the surrogates, young, healthy women, even if they become infected while they're pregnant, usually they don't have a very serious illness. So if you keep this in mind, you say, okay, then we can start. And then you implement what we call the COVID protocols, in the office and outside of the office. I think you can do it very safely. So basically, we talk to the surrogate, explain all of that. Yeah, they already know, they have a family, they have kids, they have a husband often. Make sure that everyone is aware. We test them regularly and make sure that when they travel safely. Now, now that there's the vaccine, of course, it brought up new questions. For example, should the surrogate be vaccinated when she's pregnant? Should we wait until she can get vaccinated before she becomes pregnant? The problem is that, it sounds like, the vaccine is truly not a real option for most people in the US, unfortunately, at the moment. So I think, for example, waiting for the surrogate to get vaccinated is really not practical for most people. But if she has an opportunity, and we've had surrogates, many of them like, healthcare workers that have access, absolutely, they should be vaccinated. I think the vaccine is safe and very, very highly effective. I think very soon, within a couple of months, there will be enough data to support using it in pregnant women as well. So yeah, of course, if you have access and you can get vaccinated before you get pregnant, absolutely. But I don't think it's necessary to wait.
And you wouldn't recommend to be vaccinated during the treatment, correct? Like during the actual cycle itself? No, in preparation, like during the IVF cycle itself. So prior to, I would assume, and then maybe pregnancy.
Well, there's no problem. The studies, at least the data we have now, is that, for women who are planning to become pregnant, 5 days after the second vaccine, they can get pregnant and not have to worry about it. So yeah, you can do it up to the last minute.
Okay, perfect. Is there anything else, Dr. Levy, that you feel is important to share during the webinar? I know we have our slide here, so we don't leave anything out, as I know our hour is wrapping up.
Yeah, I think this sort of summarizes everything that I said. And I think really, really important, again, to emphasize that this is all a team effort.
Mhm.
So it's, the clinical team, the coordinators, the agency, the surrogates, the egg donor, everybody sort of works around the parents to make it, basically what I call, a simple, safe, and successful journey.
Right, it's a very regulated process. So when you're working with, an agency and the fertility center and the attorney, we really piece it together. So it should be very smooth, and the steps are aligned nicely. While waiting to be matched with your surrogate, which typically is around 2 to 3 months, is a good time to start the creation of the embryos. We feel during that downtime if they don't have embryos yet. So we did have a few more questions, but I know we're running out of time. So definitely there was some questions about the financials, the cost in packages, but definitely anybody who has questions, feel free to email us. We are definitely happy to answer those questions. There's still some questions coming in. I feel awful.
Yeah, there is.
There's so many, and I want to answer them all, but but we will for sure after the webinar. But definitely, ask us those questions. We will get those answered. But we really thank everybody for your time. I feel we could talk for hours about this, right, guys and ladies?
Exactly. Yep.
There's so much, and we would like to share. But yeah, we thank you so much. This will be recorded, and it will also be on our websites as well. So we're happy to share the link to this as well for anybody who maybe has missed it or wants to watch it again. But yeah, thank you everybody for your time, and Dr. Levy and Shantae, Perla.
Thank you, Stacy.
These are amazing.
Yes, thank you all.
And thank you for what you do every day.
Thank you. Thank you.
All right.
Yeah.
Have a nice evening, everybody.
You too.
All righty.